Thank you very much. I hope everybody enjoyed lunch. So, our session is quite packed with information, but we would like some interaction from you as well. We're going to start with a brief background of proning. We're going to look at the mechanisms, indications, contraindications, complications, how to prone, and finally finish with some cases to be discussed with you all. When I was thinking about the history of proning, I think it's very important that we take a look back sometimes. We've come a long way in the last 50 years with many aspects. Treatment of ARDS, lots of new therapies, lots of things tried, some things dismissed. Proning's been with us for a lot of that time. And something struck me recently was my father bought me a book from a second-hand shop called Automatic Ventilation of the Lungs, second edition, 1969. And I just wanted to share a quote with you from it about mechanical ventilation. They acknowledged that mechanical ventilators were quite useful for sometimes no other reason than it stopped anaesthetists having to keep bagging. But they also said, and bear with me, no mechanical device can altogether take the place of sensitive and skilled hands squeezing a reservoir bag. To believe, as some do, that a machine, however elaborate, can give an anaesthetic or treat respiratory insufficiency is a point of view which cannot be accepted. 50 years ago, we've come a long way. So, we can't talk about the prone position without talking about ARDS. This paper was mentioned earlier by Prof. Habashi. Prof, not only have I read it, I've also got a copy in my handbag. But they recognised 12 patients that weren't responding in the way that patients normally do. So there began the story of how do we treat these patients. It was another 9 years before we started to talk about proning in humans. There'd been some animal work that showed that actually proning improved oxygenation. Peel and Brown were offered the opportunity of using the circoelectric bed, more about that later, in order to see what the impact of proning patients would have on PaO2 levels. So that was the premise of their study. So when did they prone the patients? They were patients who were on FiO2s of greater than 60% with high PEEPs, PEEPs of 15, 16, 17. Why did they do it? Their hypothesis was that it improved VQ mismatch and also helped with drainage of secretions. How did they do it? They used a mechanical bed. And as I say, more about that later. And who were their patients? And I think it's interesting to read and to hear about these patients. There were 5. The first patient was 47. He'd been in an accident. He had multiple fractures and, interestingly, a flail chest. Fat emboli as a result of the multiple fractures, developed RDS. He was proned. Oxygenation improved spectacularly. Second patient, 19-year-old gentleman. Gunshot wound to the chest and the abdomen. Nasty, sucking chest wound. Really difficult for the nurses to manage from a dressing perspective. They proned him, improved his oxygenation spectacularly. But they also noted that it helped with drainage of secretions and that they were able to dress the chest wound more readily. All good. 57-year-old gentleman. He had a FEMPOP bypass and then, unfortunately, a pulmonary embolism. They proned him, improved his PO2s spectacularly. Unfortunately, he died 7 days later of cardiac failure, but his PO2s improved. That was really good. Their youngest patient, 7-year-old little boy, been involved in a road traffic accident, cerebral pulmonary contusions, ruptured spleen, and they also noted had recurrent pneumothoraces. They suggested, possibly down to the fact he was needing airway inspiratory pressures of 50 to 80 centimetres of water to maintain normal oxygenation. They proned him, PO2 went up beautifully. And their final patient, eldest patient, 78, AAA repair, 4 days post-op, developed ARDS, proned, PO2 improved spectacularly, went home 35 days later. So what is the message that we're taking from this? They had a theory, VQ mismatch improved, increased drainage of secretions. Their oxygenation improved, they had 5 responders, and aren't we fortunate? Because if they'd failed on all counts, would we still be proning today? They may not have been proning for the right reasons. We now know, as Prof. Bashley pointed out earlier, it's so much more than the oxygenation. We've continued to do it over the years. Sometimes it's been in fashion, sometimes it's been out of fashion, while we've desperately sought the evidence to underpin what we're doing. But we've kept doing it. And now Guy will discuss in more detail.
Sarah, that was a really wonderful introduction, and in fact has encouraged me to go back and read the paper, which I confess I haven't, but what a fantastic historical description. So let's look in a little bit more detail about the prone position. Sarah has alluded already to some of the mechanisms that were proposed initially for why this therapy may be effective, and these are things that we've looked at already. There's been a lot of focus initially on the impact of ventilation perfusion matching, but actually I think there's an increasing understanding that the benefits of the prone position go beyond that, and that actually the impact on lung mechanics is probably more important in terms of homogenizing the pressure gradient from the ventral to the dorsal regions, avoiding the overdistension of the ventral regions and the de-recruitment of the dorsal regions, and therefore leading to a sort of gravitational recruitment of those lungs without the associated overdistension of the ventral regions that might be associated with using PEEP to try and achieve the same thing. Also, drainage of tracheobronchial secretions, as Sarah has already discussed. I quite like this as a model to try and help me understand how this might be effective. This is really just sort of modelling, really, but in the top row, you can see the supine posture, and they suggest that the chest is effectively in a sort of triangular pyramidal sort of shape like this. The lungs, I should say, once you put the lungs inside the chest wall, they get stretched out in that way, and you can start to see how the ventral regions, because of the pleural pressure gradient, start to overdistend at the top. And then once you add in gravity to that, you can see that we've got this significant overdistension of the ventral regions with with de-recruitment of the dorsal regions. If you contrast that to what happens if you apply that model in the prone position, then you can see again that homogenization of the pleural pressure gradient means that you don't get these extremes of overdistension versus de-recruitment, and hence more homogeneous ventilation. These are my thoughts, really, more than anything else, based on what I've read, but also what I've observed at the bedside with a real enthusiasm for proning patients. And I think you can identify several phases in the response to the prone position. Of course, we must be clear, not all patients will respond. Of course, they won't follow this, but this might be considered to be a sort of typical pattern. So what you can see is a sort of delta in the PA FiO2, and again, I've got my rose-tinted spectacles on. I'm rather assuming here that all of the patients improve. Of course, again, we have to be absolutely clear they do not all, but if we look at responders, why and how might they respond? So it would appear that quite often, in fact, it's described in a good proportion of patients, you get this initial and very rapid improvement in PaO2 FiO2 ratio. That's very likely to be associated with this very rapid improvement in VQ matching. But in fact, if you follow the red line back down, if you were to immediately supinate the patient again, then of course that effect is almost immediately lost. You've gained nothing and you're back at square one. However, if you leave the patient in the prone position, then you can see that the patient continues to move up this curve of improving PaO2 ratio. And why is that? That's for the reasons that we've discussed, which is that over time, you get this passive and gravitational recruitment, predominantly of dorsal lung regions. What happens after that depends whether that recruitment is sustained. If you don't have sufficient PEEP, or if you have insufficient resolution of the underlying condition and you deprone the patient, then it's quite possible that they're going to follow this red line down here, and the effect is effectively lost. You might have some overall net benefit, but that significant thing is lost. However, if you can sustain that with, for example, a high PEEP strategy, then you can find that even after the patient's been supinated, that response is sustained. On top of that, you can, in fact, potentially augment the benefit by performing a recruitment maneuver in the prone position after a period of time, because it's likely that the response of the lung to the prone position is likely to be different to the response in the supine position. So again, you can get this further augmentation in response to recruitment maneuver. So these are the respiratory effects. What about cardiovascular effects? We know that ARDS is commonly associated with shock, and we know that it's commonly associated with acute cor pulmonale, and we can see in the figure on the top left-hand corner a clear association between the occurrence and the severity of acute cor pulmonale with mortality. So clearly this is something that is problematic, and what we can see from this study in the bottom left-hand corner, sort of physiological study, is in actual fact pulmonary vascular resistance by and large will decrease in the prone position with a commensurate increase in cardiac output. So lung recruits, pulmonary vascular resistance decreases. You may also get some central, some loading of the central blood volume, decrease in RV afterload, LV preload increases, and all being well, you get an increase in cardiac output. So again, this is not seen universally, not all patients respond in this way, but commonly you'll also see an improvement in shock associated with the prone position. I'm sure you'll have seen this slide already, but we need to move on to the question of who do we prone, where does it fit into this huge range of options that we have in terms of this sort of bespoke approach that we want to take to the management of the patient. And we can see, you'll have seen this slide already, prone position fitting in here, moving up towards the top right-hand corner of the slide, severe, perhaps moderate to severe, in the new definitions, ARDS. So this is predicated on the recent trial data that we're going to look at very shortly, but we would generally consider that prone position is indicated for patients with severe ARDS, requiring what I would describe as moderately high FiO2 and moderate PEEP. And I think the important thing to bring out from that is that we're not necessarily talking about using this as a rescue maneuver. Commonly, in our experience as a tertiary respiratory failure centre, we find ourselves discussing the use of prone position with referring centres for patients who are already in extremis, who are already have had maximal recruitment in the supine position, are on maximal FiO2, and only then people are thinking about moving the patient into the prone position. And we might argue that, in fact, there may be a role for this therapy somewhat earlier in the patient's clinical course. I've already indicated why it is possible that acute cor pulmonale may in itself be an indication to consider the merits of the prone position. And as ever, because case selection is absolutely key, we need to understand that there are potential benefits from the prone position in terms of lung protection as well. We talked a few moments ago about how the prone position can reduce the over-distension over the ventral lung regions, and so it may be the patient population who we think are at risk of over-distension, perhaps who already demonstrate barotrauma, who may also have more of an indication for the prone position in order to protect those ventral lung regions in that way. It's commonplace in our practice to use, we're increasingly using CT scanning to understand the nature of the patient's lung sort of architecture, their pattern of aeration and non-aeration. And the question is that often comes to mind is whether the CT itself is predictive and whether we should be using the CT appearances to guide us as to who we should and who we should not prone. You might recognize CT scans that look a little bit like these ones. Now, given what we've already discussed about the potential mechanisms of action, it's very tempting to assume that the patient who's in the top right-hand corner may behave differently from the patient who's in the top left-hand corner. And in actual fact, I find myself in my practice also having those thoughts and perhaps being influenced in that way, but in actual fact, it's not necessarily predictive, and even diffuse patterns do not preclude a response to the prone position. So what about contraindications? It's often not that people are not keen, but people are often very concerned about the potential adverse effects of the prone position. And many of these things are things that might be considered to be contraindications. I think, in my opinion, I think many of them ought to be considered as relative contraindications rather than absolute, although, of course, these have to be considered on a case-by-case basis. Clearly, there is a threat to the airway in moving the patient, and I would certainly consider the difficulty of the airway, if you like, in terms of whether I do or don't turn the patient into the prone position, and also the expertise of the people who are around in our ICU. And certainly, if, for example, we had a recent tracheostomy, again, I would factor that in. Raised intracranial pressure is often considered to be a contraindication. I don't know if there's anyone in the room who works in a neurointensive care unit. In actual fact, I would consider this to be a relative contraindication. There are some small sort of observational or physiological studies that show that actually the increase in intracranial pressure, if you get this right, are actually sometimes quite modest. So probably not an absolute contraindication. Trauma, I guess, speaks for itself. Now, what about hemodynamic instability? I think this is a very difficult question. I've already said to you that you can get potential improvements in hemodynamics, but let's not be naive. Often these patients are in severe shock. Sometimes they're in multi-organ failure, very acidotic, so on and so forth. I am also cautious about proning those patients. Sometimes we do see hemodynamic instability associated with going prone. I don't have an absolute threshold, certainly above something like half a mic of noradrenaline, that's equivalent. I start to think pretty hard as to whether this is the right thing to do. Certainly, if we had recent cardiac arrest, whatever it is, again, I think you've got to think very hard about that sort of thing. Depending on what sort of hardware you've got in the patient, balloon pump, hard to imagine how that's going to work, recent cardiac pacemaker, so on and so forth. Pregnancy, we've proned pregnant patients. The last one that I can recall doing was about 16 or 18 weeks pregnant. So it's not, again, probably relative contraindication. Probably if you're got to preterm, then that's going to be a bit more of a problem, I think. What about obesity? We've got, like probably everybody in the room, an increasing burden, if you like, of obesity in the patients that we manage. And often these are the patients who are often most difficult to ventilate if one takes a conventional approach. And we find ourselves thinking about it. Is it a contraindication? I don't think it is. But certainly you need to have the experience, and particularly of the whole team, if you're going to start proning patients with BMIs over 30, 35, 40 or above, all of which we have experience of, but it is challenging and you need the right team around you. Abdominal surgery, again, might be considered to be a contraindication. The evidence doesn't necessarily support that. There's been some recent observational data that suggested no increase in surgical complications in patients who are proned after recent laparotomy. There we are. Sarah talked about proning having been over a journey, and certainly over the course of my career, I suppose this is about where my career started around this sort of time, we had proning being subjected to randomized controlled trials, and what this trial demonstrated was what had already been shown, which is that the prone position is clearly associated with improvements in oxygenation. And this is a patient, this is their cohort undergoing repeated episodes of proning, an improvement in PaO to FiO2 ratio, but you might recognize this curve from the graph that I showed you earlier, in that once the patients are supinated, they're coming back, perhaps if not to baseline, not terribly far from their baseline again. So they're getting this initial improvement, but it doesn't seem to be sustained. And they continue it over a period of time, but there's no overall improvement. They're just temporizing the situation, and in this trial there was no improvement in mortality. Several trials in the interim, but this is the one that many people will be familiar with, and this is the one that I think has given us the green light, if you like, to start to reincorporate this in a slightly more routine fashion into our practice, the ProSEVA trial, severe ARDS, and really dramatic reduction in mortality. It's very interesting to think why that mortality reduction is, in some ways, almost an order of magnitude above what you might see in some other sort of trials, and that's an interesting discussion in its own right. But that's trial data almost at either end of the spectrum, and as Sarah described, this is effectively a journey. If you look at all of the proning trials in the top figure, you can see that there has been this tendency to show increasing benefit from the trials over time. Now, why should that be? What lessons have we learned about proning over those intervening years that have enabled us to modify the technique in order to improve the way we're doing it? Well, there seem to be at least three factors that I'm aware of. The first of which is that this is a sort of co-intervention with other evidence-based therapies. So if you look at those trials according to the ones that applied lung protective ventilation versus or less strictly lung protective ventilation, the benefit from prone position seems to be greatest when it's a co-intervention with lung protective ventilation. It also seems to have the greatest benefit when it's applied for the longest period of time, greater or less than 16 hours. And it also seems to be related to the severity of hypoxemia to which it's being applied. And some of those early trials were taking a much more heterogeneous group of patients across the whole spectrum of hypoxic respiratory failure. And yet there was a signal that developed over time that actually probably if we take patients at the more severe end of the spectrum, these are the ones who appear to benefit most. So one of the questions that we're often asked is this one: is the prone position safe? Well, we've talked about contraindications, but if we are going to proceed with the prone position, is it safe? These are some of the problems that you might see in your practice and that certainly we have experience of in ours. Facial and conjunctival edema is almost universal, often more of a cosmetic problem than a real one. Pressure sores, cardiovascular instability, again, I've painted a slightly rosy picture of patients all improving. Of course, we know that's not the case. We know that some patients are destabilized. And the one that's most feared of all, I think, probably certainly in our intensive care unit, is airway complications. Obviously, in patients with severe respiratory failure, ventilated, often high-pressure ventilation, particularly for therapies that are going to be prolonged and therefore might continue out of hours when there's less senior cover in the ICU, the threat of risk to the airway is very real, as it is to other drips, tubes, so on and so forth. Are those concerns justified? It depends where you look. There's sort of different signals really in the data, but overall it doesn't look too bad. If you look at sort of gross hemodynamic instability, actually in some studies there's actually a lower incidence of cardiac arrest, perhaps because of the improvements in respiratory and cardiovascular physiology that we've discussed. What about airway complications? There might be a trend, I suppose, but it's not really gross. It's difficult to say for sure, isn't it, with data like this, because ultimately it boils down to the individual patient, it boils down to how you do it, it boils down to the skill and expertise of the staff who are there. So maybe a slight signal, but there are a lot of patients represented in this data here, and overall there is no clear signal to harm. What about pressure ulcers? Pressure ulcers is probably a real thing. It is probably a real thing. Sarah is going to describe a technique for you in a short while that we use routinely in our ICU. But pressure ulcers, I think we need to be very careful, particularly when we're dealing with a population who might be very edematous, hypoperfusion, vasopressors, so on and so forth, and particularly if we are using prolonged therapy. The last of my slides for now is to try and answer this question. Again, this is one that's commonly posed. So we prone the patient and it works, fantastic, but how do we know when to stop? Well, we've already said that proning should, provided the patient's stable, should be applied for a prolonged duration, so sort of minimum really now of sort of 17 hours per session. And then the question is, how many sessions should one apply it for? What we sometimes see in our practice is that you prone the patient, they get much better, you turn them supine, after a while they still look pretty good, you decide not to prone them again, and then by the following morning you're back to square one. And I'm often of the view that in fact a course of proning, if you like, my default position is that it's often 2 to 3 days, 2 to 3 sessions of proning. Of course, tailor that on a case-by-case basis. What does the literature say? The problem is the literature doesn't really help us so much, I don't think, because the literature, this comes from the ProSEVA trial, this is what they did. They say if the PaO2 FiO2 ratio is greater than 150 millimeters of mercury or 20 kilopascals, with a PEEP less than 10, FiO2 less than 0.6, that, well, certainly they stopped, and they seem to have a benefit, so it might seem reasonable for us to do the same. The problem is we almost never have patients with a PEEP of less than 10 who are, with this sort of therapy. So what I don't know, and I'll be very interested to hear the view of perhaps other people on the panel later if we have questions. Often, we use proning as a co-intervention with something like APRV. And what do I do? If I've supinated the patient, but their mean airway pressure is still 24, what do I do? They no longer fall into this evidence base, really. And so sometimes I think the oxygenation index is possibly more helpful in helping us guide when it's reasonable to stop. Clearly, if the patient's got worse rather than better by proning, then you probably ought to stop. And certainly if they've suffered significant complications, again, that would be a sign for us to stop. As with everything in life, practice makes perfect. I think what is clear is that, as with most things, there is a relationship between volume and outcome. This is not something to try for the first time when you're in extremis, and we really do benefit in our practice from a sort of multidisciplinary approach to this, and to having the expertise of people like Sarah and her colleagues as clinical nurse specialists in respiratory failure. Sarah is going to describe for you just now the technique that is in use in our hospital.
Thank you, Guy. Can I have a show of hands of who prones regularly? Okay, good. Good to see. So this may appear very familiar to some of you. What I wanted to do, I mentioned earlier the circoelectric bed, and I'd like to take you back to 1976 to state-of-the-art technology, 1970s style. That's how they proned their patients. Quite frankly, I find that terrifying. And I'd just like to bring you forward now to 2017 and show you our state-of-the-art proning equipment. 4 pillows, 2 wide sliding sheets, and some jellies for the head and for the ankles. And I think the message here is very clear. Keep it simple. By keeping it simple, you're going to encourage staff to engage with it. What are we going to do? We're going to risk assess the patient. We're going to look at any contraindications, as Guy's already discussed. Is the patient appropriate to be turned? We're going to assemble the team, and this should be the multidisciplinary team. We're a large unit at Guy's and St Thomas's, so we have a lot of people around. I appreciate that some units don't. But who can you call upon? You can call upon your doctors, your nurses, your medical students, your physios, your nursing assistants, student nurses, anybody around who's had manual handling training, because you want to also make sure that your staff are safe. Complete the checklist. I'll give you an example of ours. Have a timeout. So before you start, your patient's prepared, make sure your team's prepared, everybody knows what they're doing and who's going to be leading the turn the patient. Apologies for the busy slide, but this is our pre-prone checklist. And if you glance through some of the points, you'll notice that actually a lot of it is fundamental nursing and medical assessment of the patient. These are facts that actually you should know from your initial assessment of your patient at the beginning of your shift. Preparation, preparation, preparation. And don't forget to let the family know. There's nothing more terrifying for a family or for a visitor to come onto intensive care and to see that their relative is being nursed on their face. How do we do it? We favour the Cornish pasty method. And for those of you not familiar with Cornish pasties, that's the yellow thing in the middle. We call it the Cornish pasty method because we roll the patient up as tight as can be between two bed sheets, pillows across the chest, pillows across the pelvis, in order that when we turn, the abdomen hangs free. And some people think that the rolled ends of the sheet looks like a Cornish pasty crust. What do? We slide the patient across the bed. That's the first manoeuvre. Second manoeuvre, we turn the patient onto their side. Third manoeuvre, you'll see there's an exchange of hands from the team on the left to the team on the right. Once the team on the right have firm control of the patient, the team on the left let go. They then take hold of the wide sliding sheet underneath the patient and pull. And as they pull and step back, following proper manual handling technique, the patient flips onto their stomach. Once in the prone position, we favour swimmer's arms, and we alternate the arm position and the head position every 2 to 4 hours. Guy talked about pressure area care. This is one way that we actually monitor what is happening with the face and with the eyes. Although I appreciate that may be different practice to some of you. I'm also aware people nurse patients face down and with the arms down by the side. This is what we do. Top tips. As I said before, preparation is the key. Making sure you do your risk assessment for patient and also for your staff. Using the wide sliding sheets has, in a way, been the major change in the last 20 years of how we prone, and the feedback from staff has been extremely positive. Utilise the whole ITU team, and then it's about the timing. Guy mentioned we're talking about 17-hour periods here. We find what works for us, because we have an evening ward round and a morning ward round, is on the evening ward round, we turn the patient prone, we leave them prone overnight, we supine them in the morning on the morning ward round. That way they have a few hours during the day where they can have their x-rays, they can have their assessments done, wash, access to their face. And once you've done it once, don't forget, you're going to repeat. These patients need to be proned more than once. And that's the end of my session. And we'll take questions, I think, afterwards.
Yeah, that'd be great. Thanks.
Okay, thank you for that, Sarah. So what, I think we've just got a few minutes, perhaps 5 minutes or something. Is it okay? What I wanted to do was just, I appreciate there will already be a lot of experience in the room already, and might be an opportunity to share some of your cases, I don't know. But what I wanted to do was just picked out a few of the cases that stick in my mind, and I've tried to pick cases that try and illustrate something about the principles that we have already described. And of course, it's always nice to have a little bit of weird and wonderful thrown in there as well. So what have we got first of all? Who's this? Yes. So this was young chap. People will recognise people like this. So he's morbidly obese. He's got chronic respiratory issues. He's got chronic core pulmonale as it happens, and he gets tipped over the edge by a trivial lower respiratory tract infection. He has chronic fluid overload from his core pulmonale, and in fact, there's a little bit of aspiration in the mix as well, and he has severe hypoxic and hypercapnic respiratory failure. The patient gets intubated, a lung protective approach is applied, if you like, and the patient's proned. And as we have seen over the course of the talk, the patient has an excellent response, so PaO2, FiO2 ratio dramatically improves. The problem is when he's supinated again the following day, much as I have described before, he's back at square one. And that process is in fact repeated 2 or 3 times. He gets proned, improves, supinated, deteriorates, and so on and so forth. So how are we going to break this cycle? Of course, we're trying to treat the underlying condition, but he doesn't seem to make any progress. And the difference, the final time, seems to be that we prone the patient, and again, we use it as a co-intervention. I don't know if Prof. Habashi would support this, but we use it as a co-intervention with a sort of open lung strategy. We use APRV on this occasion. Bear in mind, this patient has got a BMI of 42, is very fluid overloaded. So we prone and apply APRV, and the following day, when we supinate the patient, in fact, the improvement is sustained. And on that basis, actually, he progresses and weans very quickly. And if we just go back to this for a moment, hopefully this now illustrates a sort of real-life example of what we were talking about before, which is what was happening is we no doubt got this, and then we probably even got a little bit of this as well, but we didn't have this. As I said, we were applying, that's why I put lung protective strategy in inverted commas, because we had a sort of modest PEEP strategy, modest driving pressure, and as soon as we see it just simply was not enough PEEP in order to keep lungs open. So we ended up doing this. What about this? This is something that may not be the bread and butter for many people in the room, but it's something that we do not infrequently. So Guy's and St Thomas's runs a regional sort of tertiary referral network for severe respiratory failure and ECMO, but sometimes we have patients like this one. So this was a patient who is a little bit older for the patients that we have, and importantly, there was a history of sort of chronic respiratory illness. And then when he presented, yes, he very likely did have community-acquired pneumonia, but there was a significant suspicion that he had a progressive underlying interstitial lung disease. On that basis, I'm not saying he was necessarily excluded from ECMO, but we didn't think it would be an appropriate sort of first-line intervention, if you like, from our service. We recommended proning. The patient was proned, and in fact, the patient responded. The problem was we wanted to get the patient back to our hospital, not so much for us, but in fact for sort of tertiary respiratory interstitial lung disease expertise. And yet here we had the patient proned, much improved, and yet we had to move them. Well, I had essentially 3 options. I could either supinate the patient, in which case they were very likely to get worse again, and then be faced with how I move a hypoxic patient in the supine position. I could have put him on ECMO, but I've already said why we didn't want to do that. So we had a third option, which is simply to move the patient in the prone position, and that's exactly what we did. So this guy, he was not small, I have to tell you. He was probably 90 kilos, although we have done bigger. And he was transferred probably about an hour, 25 miles or so, on a stretcher in the back of an ambulance in the prone position. It's absolutely fine. We've done this maybe, I don't know, a dozen times, that sort of thing. I think case selection is key. You certainly need the expertise of the personnel, airway assessment, so on and so forth, absolutely critical. But it certainly is possible. It certainly is possible. In actual fact, this sort of thing is also well described in the literature. If you look in the sort of retrieval literature, it's well described. There are retrieval teams in more far-flung places around the world than this one, doing quite a lot of this sort of thing. And the growth of ECMO, I think, is probably making it less of a frequent occurrence, but nevertheless, we're doing it. Now, what about this? Proning on ECMO. This sometimes raises a few eyebrows. So we have quite a few patients on VV ECMO. And this is just one example that I want to share with you that, again, hopefully illustrates that there is more to the prone position than improving gas exchange. So this was a middle-aged sort of guy, truck driver, community-acquired pneumonia. He didn't really have ARDS. He just had severe right lower lobe community-acquired pneumonia, pneumococcal, most likely, from memory. If you tried to perform a recruitment maneuver on this guy, he basically got worse rather than better, because all we were doing was over-distending the normal bits of lung and making no headway whatsoever with the consolidated lung. And this guy was also pretty chunky, 130 kilos or so, and I didn't fancy transferring him in the prone position as it happened. So we put him on VV ECMO, which was fine. We transferred him back to our hospital, and then we turned him into the prone position on ECMO, 130 kilos, and what we found was, again, this sort of gravitational effect, whether it be drainage of tracheobronchial secretions or the redistribution of ventilation, In fact, his right lower lobe opened up very quickly, and there was a really dramatic response, again, such that he was weaned off ECMO very shortly. So I think it's not paradoxical or contradictory to use these things, again, as co-interventions, and certainly more to, more to the using the prone position than merely improving gas exchange, which had already been addressed by ECMO in this case. I just want to very briefly share with you 2 or 3 cases. And what's interesting about these is not the duration of doing it, but what I hope you see in these cases is about case selection. And it's also an honest appraisal of the prone position, because despite everything that we've said so far, you will know and we know that it doesn't always work. And I want to share some of those cases as well, in doing so, trying to illustrate how we make these difficult decisions. So the top one, I'm not going to go into a lot of detail. It was a young patient. He had flu B. He was referred to our service. We were going to put him on ECMO, but actually it wasn't too bad. So we brought him back on a conventional ventilator, and then we proned him. And in fact, he was also proned and on APRV. He got better. And every day he was just that little bit better, but it wasn't really dramatic. And before we knew where we were, we'd pursued this strategy for 7 days, proning every day for 7 days on APRV. And perhaps not entirely surprisingly, in retrospect anyway, after 7 days, he had pneumomediastinum, and we decided enough was enough. He had not responded. His underlying condition had not improved sufficiently. He ended up going on to VV ECMO, in fact had a very long and stormy course with evidence of pretty clear ventilator-induced, or clear in my view anyway, ventilator-induced lung injury, which took a very long time to get better. And in my opinion, I think we probably over-ventilated that patient for a little bit too long. This is another case. Again, middle-aged lady, viral pneumonitis. She was proned in a referring hospital. Again, she did well. She did so well in the prone position and so badly supine that they basically left her continuously prone for the best part of 72 hours. I kid you not. In 72 hours, she had 2 hours in the supine position for a line change. Sarah's sort of, you can't see Sarah's face, but she's pretty horrified, I'll tell you. Again, it's probably, in my opinion, not necessarily the right approach. If somebody's so bad that they cannot tolerate a moment in the supine position, it's probably not reasonable and not safe to keep someone prolonged in the supine, in the prone position in that way. And not surprisingly, she did indeed have pressure ulcers ++. So there you go. It's really, we've got to understand that the prone position is part of this range of options that are available to us. We need to know where it fits in, but also we need to know where to escalate and to do something different. Just want to end on a slightly more positive note with this lady for whom the prone position I think really was a lifesaver. So this is a very young lady, mother of 2, and it was clear at the time that she presented that she had something very nasty going on indeed. And it rapidly became apparent that she had an underlying malignancy. She had hypoxic respiratory failure. We brought her back on that basis. We felt that she was unfortunately excluded from being eligible for ECMO. She was transferred back conventionally. We proned her. We did a lung biopsy, which made the diagnosis so exceptionally rare. She had a T-cell lymphoma infiltrating her lungs, and she was given chemotherapy on a ventilator in the prone position in the ICU. And what was remarkable about this case was remarkable to me anyway, was that she obviously took a long time to get better. Obviously, chemotherapy doesn't work overnight. And she had 3 prolonged courses, if you like, of the prone position. I've estimated more than 10 days because I didn't want to be caught out exaggerating. But if you ask me, I'm pretty sure it was more than 2 weeks in total. Remarkably, it all sort of got better. Had a tracheostomy put in, she woke up, she got better, she left the ICU. She did ultimately die, unfortunately, but we brought her several months, actually, with her young family. So worthwhile doing, I think, in that case. So thank you very much for allowing us to present to you today. I think in summary, we would come to these sort of conclusions. I think with appropriate expertise and experience, I think the prone position is fundamentally safe, and I think it is very often, not always, but very often effective. And I think it is very important that we understand that there is more to it than simply making the numbers better in terms of the blood gases, in terms of lung recruitment, actual resolution of the underlying pathology. And it's important that we see this as something other than a rescue technique, that we don't wait until it's too late. If you do that, you'll very likely have a very negative perception of the prone position, or there's a chance that you will, because it becomes self-fulfilling. If the patient's in extremis by the time you do this, there is a fair chance that the prone position will be associated in your mind with a negative outcome. If one uses it slightly more proactively, then you may begin to see the benefits. This is only one part of good sort of ventilatory and respiratory care, and it's very likely that this is a co-intervention with the other basic tenets like lung protective ventilation, high PEEP, plus minus recruitment manoeuvres. Whilst I'm an advocate and enthusiast for ECMO, in my personal opinion, I think in the absence of contraindications, it is very reasonable to consider a trial of the prone position before one goes for ECMO, after appropriate discussion around that decision. And it's important to recognise that in order to realise the benefits, you often need to use this as a slightly more prolonged therapy, and yet, as I've illustrated in those last few cases, also be mindful when it's not working, and indeed be prepared to escalate and refer on if that is the case. So thank you very much for your attention.